Thank you. So we're here to talk about urosepsis and mortality after ureteroscopy, and there's a new scope that just got used for the first time in the world within the last 2 weeks by Dr. Naeem, Bhojani, and myself. I'd like to introduce Dr. Abdulghafour Halawani, our current fellow, who comes to us from Saudi Arabia, from Jeddah, and he did his residency in Sweden. And Dr. Naeem Bhojani, I'm happy to report, is joining us too from University of Montreal. He's actually here in town, here to speak at a Boston Scientific National Sales meeting. So he's been kind enough to join us. And we've done a lot of this work together. We were the first to use this scope, first in the world. And we've done a lot of publications together. So I'm really glad he could join us. So I'll pass it off to you now, Abdul.
Yeah, thank you, Dr. Chu, for the introduction. The objectives for our today's talk to discuss sepsis and mortality rate after retrograde intrarenal surgery, role of intrarenal pressure in sepsis symptoms and complications, introduce the efficacy of a real-time sensing pressure, a single-use digital flexible ureteroscope. Sepsis is a clinical syndrome that complicates severe infection and is characterized by the systemic inflammatory response syndrome. SIRS is defined as 2 or more of the following variables: fever of more than 38 or less than 36 degrees, heart rate of more than 90 beats per minute, respiratory rate of more than 20 breaths per minute, or arterial carbon dioxide tension of less than 32 millimeter of mercury, abnormal white blood cell count, either more than 12,000 or less than 4,000 WPCs per microliter. When we look at the most common pathogen causing urinary tract infection, we see the E. coli is the most common organisms, followed by some other pathogens such as Proteus, Enterobacter, Klebsiella, Pseudomonas, and gram-positive bacteria. The reported incidence of SIRS after percutaneous nephrolethotomy ranges from 16.7 to 23.4%, while after semi-rigid ureteroscope procedure, 2 to 3.8. What about the flexible ureteroscopy and retrograde intrarenal surgery specifically? Looking at the literature, the incidence of infectious complication after rears range between 2.8 to 7.5%, with a mean incidence of 7.1%. Several factors have been identified as a predictor of infectious complications after rears, including operative time, positive urine culture, history of infection or antibiotic use before surgery, positive pyuria or nitrites on urine analysis, presence of comorbidities, stone composition, surgical experience, and long ureteral stent dwell time. When it comes to the operative time, this 4-year prospective study chart of patients who underwent flexible ureteroscopy between January 2014 to January 2018 were reviewed. 463 patients in a non-infectious group, while post-operative infectious complications, including fever, sepsis, and septic shock, were identified in 31 patients. Multivariate regression analysis revealed that operation time more than 60 minutes increased the development of infectious complication by 2-fold. There is a controversy in literature whether pyuria or bacteriuria is a sensitive predictor for febrile complication post-rears. This retrospective analysis, 150 patients underwent rears from January 2014 to July 2017. We can see the univariate analysis found that the preoperative pyuria was associated with postoperative febrile UTI. Multivariate logistic regression analysis showed that the preoperative pyuria was the only independent risk factor of infectious complication after rears. Intrarenal pressure plays an essential role in retrograde intrarenal surgery and infectious complication postoperatively. If we look at the literature, there are several articles that have investigated the intrarenal pressure. What we know that the physiological IRP is around 5 to 10 centimeter of water. Intraoperatively, the intrarenal pressure is determined by irrigation inflow and outflow. High intrarenal pressure can result in severe complications such as extravasation, urinoma, sepsis, subcapsular hematoma, and focal parenchymal scarring. We go back to 1927 to evaluate what pressure are important and why. And we can see pilovenous, pilolymphatic, and pilosinus backflow occurs when there is a sustained pressure of 30 millimeter of mercury. Why is this backflow important? Because the concern that it can lead to high risk of septic complications. In a study that focused more on mini-PCNL, we were able to identify that with high intrarenal pressure, if we place a bacteria in urine, we find the bacteria not only in the kidney, but in spleen, liver, and the blood. We know that the voided urine doesn't necessarily correlate with the culture of the stone. So any patient undergoing a stone procedure has the risk of having bacteria in the stone or renal pelvis. By decreasing intrarenal pressure, the hope that we can decrease the risk of septic complication. This is a retrospective study looking at 206 patients who underwent flexible ureteroscopy. With the outcome studied is systemic inflammatory response syndrome. They found an incidence of 8.1%, and 4 different factors have been identified as associated with febrile UTI post ureteroscopic procedure. They found that the irrigant volume and irrigant flow rate are both independent predictors value for serious post-operatively on multivariate analysis. When it comes to which irrigation method that lead to high intrarenal pressure, this is another retrospective study that analyzed the data of 234 patients underwent flexible ureteroscopy. All patients had a ureter axis sheath of 12-14 French. They compared the gravity irrigation with pressure up to 200 millimeter of water versus a hand-operated irrigation pump, as we can see in the picture. And they found that the use of hand pump irrigation was associated with serious fever, hypotension, tachycardia, and increased postoperative pain. This is a randomized study by Dr. Munga's group comparing patients undergoing percutaneous nephrolithotomy with either 80 millimeter of mercury irrigation or 200 millimeter irrigation. And what they found on a multivariate analysis was that the increased pressurized irrigation was an independent predictor for serious post-operatively. Looking again at the literature, this is a systematic review, concluded that IRP should maintain under 30 millimeter of mercury. I'm sorry.
I think it was back 2 there. I promise you it's not me controlling it here. Yeah. I think it's the next one. Here you go.
Yeah. Yeah. So the intrarenal pressure should be maintained under 30 millimeter of mercury to avoid complications. Talking about the measures that can be performed to optimize the intraoperative intravenous pressure, this abstract was accepted for EOA last year, which looked at the intravenous pressure in a person model. Two different flexible ureteroscope was used, 8.7 and 9.5 French, and evaluated in combination with 4 different irrigation systems. Traxer flow, single action pumping system from Boston Scientific, Pathfinder Plus from Utah Medical, and manual pressure bag. The intrarenal pressure was measured with no ureter axis sheath, 11-13 and 12-14 French ureter axis sheath. The intrarenal pressure was significantly reduced for 12-14 versus 11-13 ureter axis sheath and 11-13 versus no ureter axis sheath. Smaller diameter ureteroscope, 8.7 French, was significantly reduced the intrarenal pressure. The single action pump system generated the greatest increase in intrarenal pressure. And they found that the highest intrarenal pressure was associated with use of single action pump system without axis sheath and the larger diameter ureteroscope. The intrarenal pressure was around 100.6 centimeter of water, while the safest combination was the use of Pathfinder Plus in combination with 12-14 ureter axis sheath and smaller diameter ureteroscope. The mean intravenous pressure was around 11.6 centimeter of water.
Okay, great. Okay, thanks, Abdul. All right. I'm gonna remote control into Naeem, and we're just gonna go through to, here we go. There you go, Naeem.
Excellent. Thank you, Abdul, for that great introduction. Thank you, Ben, for inviting me to speak today. We know from the introduction that intrarenal pressure can be related to a number of complications, and one of the complications is infectious. And so when we heard about this new scope, Ben and I, a couple of years ago, it's been at least 2 years since we've been working on this, we decided to look at some research in that area of intrarenal pressure and infectious complications. And so the first study we did, which was published in July of last year, is this one. We did a systematic review, meta-analysis, looking specifically at sepsis after ureteroscopy. And the reason we did this is because if you look at the literature, most of the studies look at infectious complications in general, but not specifically at sepsis. We looked at 251 articles, and only 13 met our eligibility criteria for that same reason. So we had a total of almost 6,000 patients. The first thing we found, which was quite interesting, was the rate of sepsis in these studies was very variable. So some were as low as 0.2%, others went almost up to 18%. But our pooled incidence of postoperative sepsis after ureteroscopy was found to be 5%. When this paper came out, this was a very impactful number. We had a lot of discussions with urologists. Some of them felt that this rate was too high. Some felt it was correct. Some felt it was too low. And there's a number of reasons for that we can talk about. But this is, very, very interesting. And we also looked at risk factors in the literature for sepsis after ureteroscopy. So we identified 13 that were in the literature, and we found 6 to be statistically significant predictors of sepsis. The placement of a preoperative ureteral stent, and this came up quite a few times, positive preoperative urine culture, ischemic heart disease, diabetes, older age, and then duration of procedure, which was mentioned by Abdul. So another, these are important factors to consider when performing ureteroscopy. So we had that meta-analysis, got a lot of reaction. We thought, we need to confirm what we found in that study. So this is our second study, which is actually under review at J-Endo. So basically what we did was we got access to a very large data set. It's the IBM Market Scan data set, which is United States data. And it's basically all employee, employer, payee, healthcare patients. And there's tons of data, very granular. But of course, it's based on ICD-9 and ICD-10 codes. So we looked at this data set from July 2014 to December 2019. We wanted to just look basically at the incidence of urosepsis. And so we had a total of just over 100,000 patients. We found a number that was, very comforting because it was very similar to what we found in our meta-analysis. So 5.5% of these patients went into sepsis after ureteroscopy. And the other thing that will come up in a few slides is there's an ICD-9 code for sepsis, and there's an ICD-9 code for severe sepsis. So this is basically patients who are even sicker. And so in this data set, we found that 1.4% of those septic patients were severe septic, and then roughly 4% were just regular septic patients. The time to sepsis mean was just under 2 days. So then we wanted to look at the impact of sepsis on the healthcare system, healthcare utilization. So here you have the sepsis cohort, and this is the non-septic cohort after ureteroscopy. You can see, obviously, most of these sepsis patients were inpatients, very few in the non-septic cohort. ICU, obviously, much more patients who became septic went to the ICU. And then, of course, length of stay doubled if you became septic. And then probably most impactful, this is US data. So a normal, quote unquote, normal ureteroscopy costs just over $17,000. If you have a septic event, that shoots up to almost $50,000. This next graph is basically comparing the regular sepsis cohort to the severe septic cohort. So as you can see, the severe septic cohort was the ones who really, were more in the ICU, had pressors, were considered to be sicker than the septic cohort. And again, length of stay, you can see, went from 6 days to 9 days, and then cost increased significantly from $43,000 to almost $70,000. Did you want to do this slide, Ben?
So one of the things that happens is if someone comes in septic and you place a stent, one of the questions is, when should you do their definitive ureteroscopy? This always comes up. This is a nice retrospective study by David Lifshitz, and essentially prolonged indwell time actually results in more sepsis. And it seems that if you look at the overall area under the curve, it's typically, that arrow's at the wrong place, around 4 weeks. So if you do stent someone for sepsis, this data suggests that you should actually do it within 1 month of stenting. But I think you found different data though, right, Naeem? Yeah,
so this is a study from 2017. So we just actually completed a similar study with that same IBM data set that we have. So here we have 30,000 patients. Again, looking at time from placement of ureteral stent to ureteroscopy. So we broke up the groups into doing the ureteroscopy within 2 weeks, 2 weeks to a month to 2 months, and then greater than 2 months if you wait greater than 2 months. And I have to say, this data to me speaks to me a lot because of our Canadian healthcare system. I can't get these patients on before a month. A month is the fastest I can get them on after they've gotten a ureteral stent placed. So the mean time here was 21 days. So ureteroscopy was performed 21 days after placement of a stent. So when we looked at the delay to ureteroscopy, we looked at a number of factors. We looked at return to ED. We looked at inpatient visits, complications, imaging, and then medical costs. And what you notice is that the longer you wait, the higher is your risk of all of these outcomes. So ED visits, inpatient visits, complications increase, imaging increases, and then medical costs, of course. And it's progressive. So the longer you wait, the higher is your risk for each of these outcomes. So, our recommendations is to try to do the ureteroscopy within 2 weeks of the placement of the stent. And honestly, I really hope that we can use this data, at least in Quebec, to convince our ORs that these cases need to be done quicker. The last study I'll show you from the same data set is actually data we're presenting at this year's AUA. So if you look at the literature, there's really nothing in terms of mortality after ureteroscopy. It's, if you talk to urologists, and you all know that, ureteroscopy is considered a very safe procedure. So we've already shown that, sepsis occurs in 5% of those patients, but now we wanted to look at mortality. And so again, we're looking at the same IBM market scan data set over a 5-year period. We basically looked at mortality within 30 days of ureteroscopy. If a patient went into sepsis, we then looked at mortality 30 days after the septic event. And basically what we found was the overall rate of mortality in patients who don't go into sepsis. So the regular patient doesn't go into sepsis, the all-cause inpatient mortality was 0.03%, which is quite low, which makes sense. However, if you have a septic event, that goes up to 0.82%. And if you have a severe sepsis event, it goes up to 2.5%. So the interesting thing here is it's a safe procedure, as we mentioned, as long as you don't have sepsis. If you don't have sepsis, your rate of mortality is very low. If you have a septic event, however, your hazard ratio is 17 times in terms of mortality. So really, really important to try to avoid a septic event. We also looked at, different factors that could predict mortality. So older age, more comorbidities were all predictors of mortality after sepsis. So main findings, again, overall rate of developing sepsis in this data set was 5.6%, 4.1 developed non-severe sepsis, 1.5 developed severe sepsis. Overall mortality rate, if you don't develop sepsis, is quite low at 0.03%. However, if you do develop sepsis, it can increase significantly. So really the key here is, avoiding sepsis. And I think this is where, our ability to, measure intrarenal pressure and then hopefully reduce septic events becomes interesting.
Thanks, Naeem. So how about antibiotics? I think the other thing I wanted to just point out about that data was that it only goes to age of 64, because this stops at age 65, because this database is only for people who are working and insured. So after 65, they actually don't follow those patients even because they're presumably not working. So what do we do about antibiotics? How can we prevent this? And we've done some work here with our EDGE Research Consortium looking at a randomized controlled trial. This was in PCNL, and this was just straightforward people, low risk population, no tubes, no infection stones. They were randomized to either 7 days of preoperative antibiotics versus no PO antibiotics preoperatively. And then everyone got IV antibiotics at the time of PCNL. And what they found that the sepsis rate for PCNL was about the same, about 12 to 14%. It was exactly the same. There was no statistical significance. Ryan Flanagan helped out with this when he was a resident here. We looked at 81 of our patients and looked at patients who went home with antibiotics versus those who went home without antibiotics. And there was not a statistical significant difference. In fact, the people who went home with antibiotics was slightly higher at 10.2, but it did not reach significance. So really it shows that the time of surgery to give one intravenous dose of antibiotics really works well. And Ryan Flanagan again did this as well too when he was a resident with us. And we looked at all the different types of stones that were there. And the funny thing was that you would just think it would be struvite stones, or we identified people who had infections, but all these stones actually had a lot of other components as well too. Only 13% of them were actually homogeneous. So don't be fooled by the fact that calcium oxalate stone formers or phosphate stone formers can not have infections as well too. This really can be associated with many different types of stones. So how do we prevent sepsis from ureteroscopy? You heard about our mortality, you heard about our sepsis rate. The Clinical Research Office of the Endo Society, or the CROWS study, again found very similar rates of sepsis that we did in our study at 4.3% if you use an access sheath. But if you don't use an access sheath, it actually goes up to about 15.2%. So certainly this probably plays to intrarenal pressure, flushing out the fluid so that you don't basically just keep putting in same infected fluid, but using a ureteral access sheath will be very helpful. But this differs, though, because other people found that a ureteral access sheath actually did not help, that the infection rate was similar, 11.6%. So again, sort of controversial and differing evidence of using a ureteral access sheath. But in terms of uncomplicated patients, basically you can just give one dose of IV antibiotics is sufficient, and the ureteral access sheath part is still kind of up in the air. I think you do need to play it case by case, though. So, if you've got a Ryan Patterson patient who has higher comorbidity and has had prior sepsis, neurogenic bladder, people with indwelling tubes, spinal cord injury, those kind of things, certainly I think these patients do require some more antibiotics, probably preoperatively as well as postoperatively. If there's other things we can do in all cases, and that's limiting surgical time, limiting the pressure. Now, Abdul showed a lot of data. Some of it is really kind of old, and as well as in animal studies. So we really have not been able to study pressure during cases and in humans. So, the other factors that influence renal pressure are irrigation, as Abdul showed, what type of flow we use, whether or not there's an instrument in there, whether you're using gravity or pressure or a hand pump, and whether or not you have some instrumentation within the channel, because that really helps as well too. And we actually did a study on the size and location of where we should put our access sheath. So what are the consequences of pilovenous backflow? What about pain? What about infectious complications? How do we answer these questions? So the first widely used single-use ureteroscope was the LithoVue. And what we showed with this, you could use this for just one single use, consistent performance, it's always available. The question is about the cost. We did an EDGE Research Consortium study. Sorry, one second. Evaluating the LithoVue versus the Stort scope. And what we wanted to look at was a stone-free rate and whether or not it was equivalent. And we compared it to our gold standard, the Stort's FLEX-XC reusable. And you'll see here that we had very similar patients in terms of BMI, stone size, cumulative stone area. However, the upward and downward deflection, both preoperatively and postoperatively, were actually better in the single-use scope. Because it's a new scope every time, you don't lose deflection over time, the cables don't get stretched, you're still able to use it very well and reach every area of the kidney. So this was the only difference. In terms of operative time, basketing versus dusting was all very similar. In terms of the stone-free rates, we did one immediately in between 4 to 10 days and then 6 to 10 weeks afterwards. It was actually very, very similar between the two groups. The one thing that was different was we did ask the surgeon for a global rating scale about which ones they preferred in terms of ergonomics and vision, and they actually preferred the reusable. And this is not surprising because the reusable has a better chip and gives you higher resolution. So the overall stone-free rates were very similar. The reusable scopes, I should say, they actually had to get repaired 8 times during this study. So we'll have to look at the finances of that. But essentially, we got about 6.6 uses between repair, which is about average from what you look at in the literature. So I mean, that would be the question is, depending on the cost of your repair, was it more cost efficient to go with the single use versus the reusable scope? So how do we know about pilo backflow, the impact and, the pain and everything? What kind of complications and how do we answer these questions? Now I'm going to hand over control to you.
Great. Thanks, Ben. Yeah, so as Ben mentioned, we were the first ones to do the clinical cases with this new scope. And we knew that was coming. And so about a year ago, we were the first ones to get our hands on the scope. And here it is. And we actually were able to bench test it, which is the stuff we're going to show now. So The two things that are important to understand here is this is the updated version from the 2015 version. So we've gone quite a bit. We've progressed quite a bit since then in terms of just general imaging, which will show you. But also what the scope can do is it can measure intrarenal pressure. And it's the only scope of its kind. So there's so much opportunity and so much learning that needs to be done, which is what we're trying to do now. So the first things we did is, so I'm going to show you some of the data that we got from the scope. So this is just the resolution testing, which I'll show you. So basically you test the resolution of the scope in different solutions and to see how good it is. And then you can compare scopes. This is a color checker. So it's another test that we ran, which I'll show you the results of. Standardized test, basically looking at these standard colors to see how they compare. And we'll show you what we did with that. So this study, which is basically finished and we just need to publish it, is basically to evaluate the new Boston Scientific LithoVue scope. It's called LithoVue Elite, compared to 3 other disposable scopes and 1 reusable scope. So we did the bench testing on pig models and cadaveric models at UBC. And we did a number of tests which are written there, but I will go through them now. So we're not allowed to show, I guess, the names of the other scopes. So they're basically, the other scopes are scopes A, B, and C, and then you have a reusable scope. But the Boston Scientific scope is the black scope, or the black line, and the reusable scope is the pink line. So so this is every scope basically. So we're looking here at deflection, up deflection and down deflection. But if you look over here, this is the summary. So basically you can see that Boston Scientific's deflection, up and down deflection, is kind of in the middle of the pack. The worst was the reusable scope, and there were some disposable scopes that were a little bit better, but Boston Scientific was, or LithoVue Elite was kind of right in the middle. Here we're looking at irrigation flow. So we did this at gravity, at pressure 150, and then pressure 300. And again, if you look at the summary here, Boston Scientific is basically in the middle of the pack, probably in the higher end in terms of the amount of irrigant you get through their working channel. Here we're looking at latency. So when the image gets to the camera or the scope, when do we actually see it? So there is a very short latency period. And again, you can see that Boston Scientific is kind of right in the middle. One of the scopes is a little bit faster. Field of view, so that's self-explanatory. Basically, we just looked at the scope a certain distance away and looked at when they started seeing an item and then when they lost that item from their image. And you can see that Boston Scientific was actually the best in terms of field of view. And then we went on to look at resolution, which was with that little piece of equipment that I showed you. And Boston, so we did this in different air, water, saline. We tried to recreate a bleeding environment with some betadine. We did it in contrast. And overall, again, if you look at the summary here, Boston Scientific actually had the best resolution compared to all the other scopes. In terms of maneuverability, so we had cadaveric models where we tried to go through the entire kidney, and then we gave a subjective rating of that maneuverability, and Boston Scientific was one of the best for that as well. And finally, we have the color checker. So I had shown you that standard color checker. And what we did, so this is something that nobody else has done. We basically wanted to find out how different the colors were for each scope compared to the control. So the control here is a digital camera. And we basically compared that digital camera's image to that color checker, which you saw in the beginning. And then you have the reusable scope, then you have these 3 other disposable scopes, and then you have the Boston Scientific scope. And so what you need to look at are these little dashed lines. So on top of this 50, that means that the colors are actually opposite than what is being, or the actual color. And then, so you want to be basically lower. The lower you are means you're as close as you can be to the original color. So you can see that the reusable scope was very, very similar to the control digital camera. And then, you have your other scopes here. And then Boston Scientific is somewhere in the middle. There were some colors that were very close to being opposites, but, it was yellow and greens, which is not something you really see when you do ureteroscopy into a kidney. So then we summarize this again. So you can see here that, some of these scopes one of these scopes was pretty bad. Boston Scientific, again, was kind of in the middle. The best was the control, of course, and the reusable scope had the best color checker. Now we're going to talk about another study we did at the same time, looking at ureteral access sheath and where you should place it.
So the question always is, where should you place your ureteral access sheath? Should you place it in the renal pelvis, inside of the in the ureter, in the distal ureter? Now we have a way of actually measuring the intrarenal pressures now during a case. So this is actually looking at different types of irrigation. This is just under 80 centimeters of gravity. You can see on the left here, this number here. So this is in a pig model, 12 millimeters of mercury. This goes up to about 55 in a pressure bag, or up to 70 something and 300 millimeters of mercury. And then we changed it to a self-filling syringe. And we also have a laser fiber in there as well, too, because you thought this would be more clinically significant, but this gets well over 100. I think it's 170 or so, something like that, 140. And then we do just a manual syringe, just a 50 cc syringe, which we often do here at UBC. And you're going to see it go up to about 180 here during the case. So now this is maybe not clinically relevant as much because I'm pushing as hard as I can here, but I just wanted to see what kind of pressure we could generate. I saw 191 there just for a split second. So now at least we have an idea. This is certainly, as you saw from Abdul's data, going to cause some pilovenous and pilotubular backflow for sure. And we measured how accurate the scope is with the bench model, and it is very accurate. The R-squared value is almost close to 1. So it's an incredibly accurate device. And like I said, we went through it with various types of irrigation methods. So when you first turn it on, you can actually set where your max pressure should be until it tells you what the alarm is. No one knows what to set that to. We have some bench data, some in vivo data from before, but what we really need is more data. And, the question about where we put our ureteral access sheath, as mentioned, is, do we put it inside the renal pelvis, just below the UPJ, or in the distal ureter? There are some people who use 35 centimeter or 30 centimeter access sheaths for everyone, men or women. Of course, men with a longer urethra, that's certainly not going to reach up into the renal pelvis. And we did 11-13 access sheaths, 12-14, and 14-16s. And we did various types of irrigation methods with gravity at 180, the pressure bag at 150, self-activated pump syringe, manual syringe, and then a pressure bag at 300. And we did that with 11-13, a 12-14, both at the UPJ, in the renal pelvis, with and without laser, and then again in the distal ureter. And I'll show you what the summary of these results are. And you can see that the pressure goes up with certain things, the 13-15 access sheath. And this summarizes everything here. So what you'll find is that the 12-14 and 13-15 ureteral access sheaths provided the lowest intrarenal pressures. So much like some of the data that Abdul showed, the bigger your access sheath, the better. The 11-13 or the 10-12s, although seductive in their size, actually do not give you the reduction in intrarenal pressure that you may be looking for. The next thing would be the location. Placing the sheath in the renal pelvis had the lowest intrarenal pressure. Now, you would think that placing it just below the UPJ might actually be better, but for some reason, it actually produced the highest amount in our study, in our pig model. Placing in the distal ureter, we actually have a theory about this because the ureter above there is actually just in communication with the scope. It actually gives it some opportunity to peristalse and actually get rid of some fluid around the scope. When you put the access sheath up just below the UPJ, the ureter is unable to peristalse and may not be able to get rid of that pressure and that fluid. So gravity, of course, had the lowest pressure, but as you know, sometimes you just can't see with gravity. Manual syringe had the highest over here, and the pressure bag at 150, the self-filling syringe, and the pressure bag at 300 were all very similar. So just because you're putting that pressure at 150 or 300 in the bag does not mean you're going to get that inside the renal pelvis, because you have all those physics laws that as you go down the tube it's going to get less, and plus we have something in the working channel as well too. We did measure the pressure in the calyx versus that in the renal pelvis, and it was certainly higher in the calyx than it was in the renal pelvis, and this stands to reason because the pelvis has a lot more distensibility, whereas the calyx is sort of a fixed area. And when you place something in the laser fiber, place something in the working channel, such as a laser fiber, as we all know, that also decreases your pressure as well too. So from this, we know that you should use at least a 12-14 or 13-15 to reduce your intrarenal pressure. You should place it inside the renal pelvis. And we don't know what the clinical significance is, but we're going to look at some of those things. So this is its first clinical use. Right here, we're just zeroing the device. Has to get used to the atmospheric pressure. You need to put it under some water. And then after it has been calibrated, then we are able to go ahead and place it inside the patient. So this takes just a few more seconds here, and then basically it'll tell you that it's ready to go. And then once that's done, then you're ready to go, and then you can insert it into the patient. Now, this is a clinical use. This is one of the first uses in the world with Naeem's case here. And you'll see we're inside an actual patient here. We're only at about 26 millimeters of mercury. And this is with an access sheath or without an access sheath, Naeem? And now we're up to,
this is without
an access sheath, and we're up to 83 millimeters of mercury when we go inside a calyx. And you can see it drops as we go down into the renal pelvis, just like we did inside of the animal model. And then this is one of my first cases. So we're inside of a patient with an access sheath, lasering a large stone, and it's about 25 millimeters of mercury, and I couldn't get it above 30. You should also note here too that the resolution is so much better than the original one, and really is starting to encroach on what it shows for our reusable digital scopes. I mean, it really is incredible. The resolution is over twice as good as what it was for the original disposable scope. And you can see here, it looks just like one of our reusable scopes. There's a bit of contrast things here and there. If the laser's firing, or if you back out a little bit, you might see some dark things. But other than that, it's pretty good. So same patient. On the other side, I did not use an access sheath because there wasn't as much stone burden. And you'll see here we go over 100 millimeters of mercury easily without an access sheath. Same patient. And when it was with an access sheath, we only reached to about 30. So what does this mean? We don't really know. Naeem and I have a study that we were about to embark on where we were looking at both the infectious complications as well as pain too. And we're going to be asking patients for their pain scores afterwards. And Naeem's got a very interesting case that highlights why we need this scope.
Thanks, Ben. So I don't know if it comes through, but Ben and I are really excited about, obviously being the first to use the scope, but also the implications. We're figuring out, how we can use this scope and the information we can get. And if you remember Abdul's presentation, he talks about 30 millimeters of mercury, which is really low. All the videos we've shown you have been higher than that. So we need to figure out cutoffs. But here's just a sort of a clinical application of the scope in our opinion. So this is a 75-year-old female that I just treated on Monday, actually. I previously had treated her, but so she has hyperparathyroidism. She had surgery, but it failed. And so she's being treated medically, long history of stones. At 2018, I treated her. She came in with pyelonephrosis. They put up a stent, and then they sent her to me, and I operated on her in 2018. I had a ureteral access sheath in, and I treated the stone. Everything went well. post-operatively in the recovery room, she went into severe sepsis. I mean, it was really bad. It's probably one of the cases, one of those cases that just sticks with you. And I was really worried about her, and she went to the ICU. And my patients don't go to the ICU. Our patients do well, they go home. And so this one really stuck with me, and she was in there for 2 weeks, and I was really worried. Anyways, she got out of there, everything went well. She also has diabetes, hypertension. And so, we treated her metabolically, we worked her up. Endocrinologists are trying to control her hyperparathyroidism, but they can't. And without surgery, another surgery, it just keeps getting worse. And she refuses surgery. She said, they did their best and they can't do it anymore. So again, she shows up in pyonephrosis. One of my colleagues puts up a stent. Here you can see the scan when she showed up to the emergency room. So basically a 1.1 centimeter stone at the UPJ, can see some perinephric infiltration. So they put up a stent and they sent her to me again. So again, I'm just repeating the last situation, but one of the differences, I have this scope now. So preoperatively, she had Klebsiella. We gave her 1 week of antibiotics. And when they put up the stent, that stone went into the lower pole. So first case, I used a 1113 ureteral access sheath, and I used pressure irrigation, 150 millimeters of mercury. So now I said, I'm going to do things differently. I put up a larger sheath, so a 1214, couldn't get it into the renal pelvis, which I would have liked to. I didn't put it at the UPJ, I put it lower than the UPJ to kind of go with the data that we found. And then I didn't put pressure irrigation. I thought, I could control the pressure more with a 60 cc syringe. I know, we showed you data where the pressures go really high with the syringe, but you can control the pressure with that syringe, or at least I thought so. So here's the video of her case. You can see May 9th, what are we, the 11th? Yeah, so Monday. Again, this is ureteral access sheath going up into the kidney. You can see the pressures here in the negatives. We get into the kidney, and the pressures now, you'll see the imaging is not great. This is a real case, and I'm just slightly pushing on my syringe, and you can see the pressure here is at 11. Okay, so
use a bigger access sheath this time, Naeem?
Yes, the first time was 1113. Now it's a 1214.
Okay.
So I'm looking at the pressure. So I was very concerned for this lady and her pressure. Obviously, I'm communicating with the anesthesiologist. He tells me everything's great as usual. So here's the stone in the lower pole now, 1.1 centimeters. Again, I know I appreciate that the imaging is not perfect. There's contrast in there, but I'm trying to keep these pressures low. So we get our laser fiber in and we start lasering this lower pole stone. And again, look at the pressures, they're around 38 already. And if you remember, again, we want to try to pilovenous backflow starts at 30. But you have to keep in mind, we don't know duration. We don't know if it's like a peak. That's the problem. All we know is that higher pressures can cause pilovenous backflow and can cause urosepsis. So just trying to keep the pressures as low as possible. But I can't. As you'll notice, the pressures keep going higher and higher. So just forward the video a little bit here. But basically, the pressures keep going higher and higher the more we treat the stones. And again, the imaging is not perfect, obviously. So we're up around 40 now. It goes up to about 50. After about 50, I start getting worried. And so what we decide to do is aspirate.
But you need to balance it too. If you turned off your flow so that you wouldn't get higher pressure, you would get the heat effect from the laser, which can then damage the kidney as well too. Yeah. So it's a balance.
Absolutely. And also a balance with vision, right? I have to be able to see what my resident's doing. Yeah. So we're floating around 50. So here I am aspirating. You can actually, no, now I'm pushing. So hold on a sec here. It'll go to aspirating in a sec. Oh boy. Sorry about that.
Okay, here, I'll play it for you.
Yeah. I think if I go forward, it's going to go.
There you go.
Yeah, so here, you just go back a little bit. So this is where I aspirate. So what I realize is that you can aspirate that all the way down to about 8 or 9, right? So here you see me aspirating, you can see some of that dust coming out, and then the pressure goes down. But the really exciting thing for me was that I always thought that once I would aspirate, as soon as I started pushing the irrigant again, that pressure would go back up. But that's not the case. What I learned was when you aspirate all this out, you have a nice 5 to 10 minute period where you can keep those pressures low. So for the rest of the case, I aspirated 3 times. It took me about a minute. And I was able to keep the pressures under 30 the whole case. And my visualization was better as well, as you'll see in a sec here. So I think this is one of the real nice applications of this scope. You can really, first of all, see what the actual pressure is. You can control the pressure, and we're learning a lot. The kidney is it's like a balloon in my mind. So the more water or more irrigant you push in, the balloon starts blowing up, and then you're basically stuck at a high pressure. And so when you aspirate, that balloon comes down, and then you have a little bit more leeway in terms of what you can do. So you can see my visualization is better, and we can start lasering again. And if you can forward down a little bit more, maybe Ben, you can see, throughout the case now, we're always below 30 millimeters of mercury, and that's probably too low. The truth is we don't know, but 30 is probably too low. I think 40 or 50 would be fine, but I just wanted to keep it as low as possible. And
how did you do? How did you do afterwards? Naeem?
Yeah,
move on in time.
Yeah, I'm done. Flip the slide, maybe, Ben. So yesterday I texted, and no, next slide. She's great. She did great. So I kept her 24 hours. This is another thing that I do when I'm worried about a patient who has risk factors, who might go into sepsis. So I kept her 24 hours, maintained on Cipro. So she had no hypertension, no fever, no sepsis, and she left yesterday. So, clinical application of this, just one of the applications. If you just go to the next slide, Ben. Lessons learned, internal pressure is like a balloon. UPJ is very, very important. I think we underestimate the importance of it that Ben had mentioned. Aspiration helps, longer periods of lower pressure. The kidney, I think, becomes a little bit more elastic, but we need to determine cutoffs, which is, again, then the next studies that we're going to be doing.
For sure. So this is some of our Twitter feed. This is my most viewed video, over 4,000 views. And when Naeem and I got to use it for the first time in the world, I think it's really exciting that we get to look at pressure. It may not seem like a big deal, but I think it's going to give us a really good tool to evaluate what's happening now. So I want to thank everyone who helped us with the bench studies, particularly the 2 engineers, Victor, and then our 2 research fellows, Roman and Alina.